The next high-risk pregnancy situation has to do with drug dependency. And as we probably all know from everything we hear in the media, in the childbearing age group, this is a growing health problem. They say that 10 to 20% of all pregnant women will use some type of illegal drug during pregnancy. That's pretty high. Cocaine is very common, but also, usually multiple drugs. And we have to assess all pregnant women for the possibility of this situation and watch for those red flags, because this is not something you can eyeball and say, oh, this woman definitely would be doing that and this one would not. Some of the red flags that we see would be late or even no prenatal care, and then difficulty following prenatal instructions. Those would be two red flags we would watch for. The big issue with pregnancy and illegal drugs is that these drugs are usually very small molecular weights, and therefore they cross the placenta very readily. And the fetus of an addicted mother has a drug concentration of 50% of the mother, but that tiny little fetus is not 50% smaller. It's a lot smaller. So this accounts for 4 to 5% of all fetal abnormalities. The drug could have a direct teratogenic effect on the fetus, or it places mom at high risk for other infections because she's not using very good judgment. Therefore, she could become positive with HIV, hepatitis B, or other sexually transmitted infections. We're going to talk about some of the drugs that are commonly used. Cocaine has become one of the most frequently abused drugs, although I would say right now, today, we might be seeing more heroin. Cocaine increases the respiratory rate, heart rate, and blood pressure, and it's very harmful because it causes extreme vasoconstriction, and that severely compromises the placental circulation. So you can see some of the things that are listed here. The infant effects are intracranial hemorrhage, withdrawal symptoms, the tremors, the irritability, the muscle rigidity, and long-term learning deficits. And we're going to talk more about the infants when we get to the high-risk newborn area. Amphetamines, actually the use was increasing with those because they were pretty cheap. The newborn becomes very jittery, poor feeder. Marijuana and hashish, you see tachycardia, and the newborn has intrauterine growth retardation and decreased intelligence. And there's also a decreased milk supply for the infant. There's this animal tranquilizer, PCP, which increases cardiac output, and it tends to leave the maternal circulation and concentrate more in fetal cells. There's the opiates, the morphine, the Demerol, the codeine, the heroin that I mentioned before. And you see pregnancy complications with that, like increase in PIH, pregnancy-induced hypertension, or preeclampsia. We use those terms interchangeably. Phlebitis, elevated blood pressure, bacterial endocarditis, and increase in HIV and hepatitis B. Again, because they're not always using good judgment, they get themselves into situations where they contract that. The fetal effects are fetal opiate dependency, small for gestational age baby, increased fetal distress, and it also makes them at increased risk for meconium aspiration. The one thing we don't have a lot of data on is the meth that is being used, and there isn't a lot of data yet, other than we do know that it is dangerous to the fetus, but there hasn't been a lot of research done yet on that. Now, alcohol, we talk about that as a drug dependency. Alcohol crosses the placenta in the same concentration as it is present in the maternal bloodstream. So again, you have a very large concentration going to a very small fetus. It's unknown if there is a safe threshold of alcohol ingestion during pregnancy. Therefore, all pregnant women are advised to avoid alcohol intake to avoid the teratogenic effects to the newborn. Women with alcohol addiction should be referred to alcohol treatment as soon as possible to help them reduce their intake. And we know that newborns can have this fetal alcohol syndrome, and the incidence of that is about 2 in 1,000 newborns. We'll talk more about that in the high-risk newborn LP. Cigarette smoking, nicotine has been shown to have teratogenic effects on the fetus, especially growth retardation. The low birth weight infant results from that vasoconstriction of the uterine blood vessels. Therefore, it limits the blood supply to the fetus. And when it limits it, the baby is not gaining enough oxygen and blood perfusion. And then you have inhalation of carbon monoxide, which is like a secondhand smoke. Now, these children continue to be underweight during their early years. They do catch up later. Smoking cessation is something we should always talk about with pregnant women. It's very difficult for the average woman to stop smoking. If they can at least reduce the number of cigarettes smoked per day, that helps to diminish the fetal effects. We do not want them using drug therapy such as the nicotine patch or the Chantix, because that may be harmful to the fetus. The next area of high-risk situation we're going to talk about is diabetes in pregnancy. This situation has to be managed by a multidisciplinary approach. You need all of these different people involved because this is a very high-risk situation. Every woman who has successful regulation of glucose and insulin metabolism before pregnancy is apt to develop less than optimum control during pregnancy just because of the changes occurring in the insulin regulatory process during pregnancy. So we're talking about every single woman. And then you take the diabetic woman, and that puts her in very difficult control of her diabetes. Let's talk about the pathophysiology. You have glomerular filtration of glucose that is increased, and the rate of insulin secretion is increased, and the fasting blood sugar is lowered. Now, all women seem to develop insulin resistance during normal pregnancy to prevent that blood glucose from falling to dangerous limits, despite the increased insulin secretion. Therefore, insulin does not seem normally effective during pregnancy. When you have a woman who has diabetes and she's pregnant, she must increase her insulin dose to prevent hyperglycemia, and that usually occurs around 24 weeks that she needs to increase her insulin dose. But at the same time, she needs to watch the continued use of glucose by the fetus, because that can lead to hypoglycemia in the mother, especially between meals and at night. The maternal glucose is transported to the fetus through the placenta. Maternal insulin does not cross the placenta. Now, by the 10th week of gestation, the fetus secretes its own insulin. So the primary problem we have here is control of the balance between insulin and blood glucose to prevent acidosis, because that's a threat to the fetus. And a constant supply of glucose is necessary to the fetus for adequate growth and development. We have two types of diabetes in pregnancy. We have those women who already come into pregnancy diabetic, pre-existing diabetes mellitus. And then we have those women who develop diabetes during pregnancy, gestational diabetes. This is where they have a carbohydrate intolerance, and it can have different types of or variable amounts of severity with the onset or first recognized during their pregnancy. About 0.1 to 0.5% of women who are pregnant already have diabetes mellitus, because well, usually diabetes mellitus has been a disease of older people. We're seeing it not to be so nowadays, but with pregnancy, we do have a small number. Research has demonstrated repeatedly that the best predictor of pregnancy outcome for the diabetic and her neonate is the degree of maternal glycemic control during pregnancy. So it is not okay to have the big highs and low dips, that she can get her blood sugar way high, then take her insulin and have it drop down. We want to try to keep it as much in control as possible because that's the best pregnancy outcome for the baby. However, we already said that it's a very difficult time to keep the glucose in control. The first trimester is the most critical time for fetal development. And so if the mother's glucose level can be kept from becoming hyperglycemic, the chances of congenital anomaly are greatly lessened. So you can see how she has to be followed so carefully by so many different providers because of all the different nuances going on in the diabetic situation. Now, the maternal risks and complications for mom, increased risk of spontaneous abortion. Look at that rate of preeclampsia, 25 to 30% higher incidence of diabetes or preeclampsia when that mom is diabetic. Also, increased risk of hydramnios, where we have that large amount of amniotic fluid, greater than 2,000 milliliters. This occurs in at least 25% of diabetics, and it's probably because hyperglycemia in the fetus causes that increased urine production. And remember, the fetus urinates into the amniotic fluid as well as swallows it. Preterm labor is a greater risk. Infections are a greater risk. We know diabetics have that greater risk of infection anyway. Risk for a C-section because these women have larger babies. We're going to talk about that a little bit later. And they have a risk for postpartum hemorrhage because they have that larger baby, larger placenta. The uterus has been stretched out more, so you have that greater risk of hemorrhage postpartum. Now, the risk to the fetus or the neonate, congenital anomalies is number one. They are 2 to 8 times greater to have, or higher incidence to have a congenital anomaly when they have a diabetic mom. Anomalies in their central nervous system, cardiovascular system, urinary system, and GI system. Now, the other thing that happens with fetuses is what's called macrosomia, and this is a very large infant. They weigh greater than the 90th percentile. They're not just large babies, they are big everywhere. The fetus responds to that maternal hyperglycemia by secreting large amounts of insulin. And insulin acts as a growth hormone, and that causes the fetus to lay down excess stores of glycogen, protein, and adipose tissue. And as I said, macrosomia is they are large everywhere, their internal organs as well as their outer body. And then another complication is dystocia, difficult delivery. Because they are so large, they're at greater risk for delivery injury. They may suffer from a fractured clavicle because it's very hard getting their shoulders delivered. They can lacerate their liver or spleen. Brachial plexus injuries and facial palsies are very common. Phrenic nerve injury could occur, subdural hemorrhage, and asphyxia just from that very slow time of trying to get that baby through the birth canal and delivered. And then in the first hour after birth, these babies are hypoglycemic because of that relationship between the maternal hyperglycemia and the amount of insulin that the baby is putting out to combat that. Therefore, their blood sugars drop dramatically. So now we have our gestational diabetic, and this is characterized by mild glucose intolerance. So these moms have hyperglycemia. About 2 to 6% of all pregnant women And most of the time it's encountered in later pregnancy, so usually 97% of the time it's in later pregnancy. There is a high probability it will recur in subsequent pregnancy, and one of the long-term implications is it does increase their risk for diabetes mellitus within about 20 years. 50% of them have that actual incidence, especially if they're overweight. And gestational diabetes is usually managed with nutrition alone. They rarely need insulin, and we never use oral hypoglycemics with gestational diabetes. These are the women who have the risk factors for gestational diabetes: maternal age greater than 30, obesity, some family history of type 2 diabetes, a birth of a 9-pound or larger baby, and any unexplained stillborn, miscarriage, or infant who has congenital anomalies. The maternal and fetal risks are the same, exact same as for the woman who comes into pregnancy already having diabetes. How we assess for diabetes is with a glucose screening test. 70% of the gestational diabetics are asymptomatic, therefore we do universal screening of all pregnant women. We can also do the hemoglobin A1C. We can check for glucose dipstick in the urine. They'll usually have some home glucose monitoring. Ophthalmic exams can look for the changes in the retina, and then the urine culture for infection. Here is a list of some of your nursing diagnoses that you may see with a diabetic, but again, remember, it has to be specific to your actual patient as far as you're related to and you're as manifested by. The nursing care and management, well, preconception care is especially important, especially when you have someone who is already diabetic. You want to begin good care and management of their glucose control well before conception. Educate them about how important that glucose control is during pregnancy. Regulate or educate them regarding their diet, and it's going to be very individualized, but usually it's 30 kilocalories per kilogram per day, but their specific endocrinologist is going to assist them with that. Educate them regarding exercise and why that is so important. And again, we're going to do good blood glucose monitoring, and we're never going to treat them with oral hypoglycemics because they actually cross the placenta. We're also, during this whole process, monitoring fetal well-being every step of the way. One of the things that we know about the fetus is that the placenta matures faster in a diabetic patient. When we're talking about the maturing of the placenta, we mean the point at which the placenta is no longer functioning at full capacity, and that usually starts the process of beginning labor. So diabetic women have matured placentas earlier, and therefore we rarely are going to let them go to full term, because at that point that placenta is way beyond its effectiveness, and that can be very dangerous for that fetus. We need to talk about the insulin management. Excuse me. It differs by trimester. In the first trimester, excuse me again, insulin needs are generally on the decline because you have the secretion of placental hormones, and that initiates the maternal resistance to the effects of insulin. But that secretion of placental hormones actually is low in the first trimester. In the second and third trimester, the insulin needs increase dramatically because those placental hormones reach their peak. And then during labor, you have to maintain very tight maternal glucose control to reduce the neonatal hypoglycemia, because remember, that baby's going to be born very hypoglycemic otherwise. So many times they need insulin IV during labor. And then postpartum, their insulin needs will decline rapidly. So we need to be monitoring their glucose levels very carefully for their insulin management needs. Timing of delivery is important. Remember, I said we usually don't want them to go to full term. So we want to try to get them to about 38 or 39 weeks to allow the fetal lungs to mature, monitor their fetal well-being, but remember that that placenta matures faster in the diabetic woman. We have a case study here that we'd like to get to in class. We have a woman who has type 1 diabetes, and she is pregnant, 12 weeks. So we want to know how her diabetes will affect her pregnancy, and how will the pregnancy affect her diabetes. What changes will she most likely have to make in her diabetes management because she's pregnant? What routine assessments are we going to make at each prenatal visit, and what additional tests will she need as her pregnancy progresses? And how may her fetus be affected by her diabetes? So we'll hopefully get to that case study in class. So another area we want to talk about is trauma and pregnancy. Trauma, as many as 250,000 women per year, and that's about 6 to 7% of them. And we have the issues of auto accidents, homicides, and suicide. Those three are among the three leading causes of death in the childbearing age group. There's a real high incidence of accidents and trauma in the last trimester because women are more clumsy, they're off balance, their center of balance is off, and they're not always wearing sensible shoes as they should, and they have the relaxin, that hormone that has been excreted into their bloodstream, so that they have the loosening of the pelvic joints, but it loosens all of their joints, so they have more clumsiness, fainting sometimes, and hyperventilation. We see more orthopedic injuries like broken wrists and sprained ankles because of that sense of altered balance. And the other thing is, in an auto accident, they are often the front passenger, and this is the person who usually receives the most severe injury in auto accidents. Some of the types of pregnancy trauma we see are open wounds like lacerations, puncture wounds, animal bites. It can be blunt abdominal trauma, gunshot wounds, and these are always reportable, poisoning, choking, orthopedic injuries, burns, and battering. A few nursing diagnoses for you to think about, but again, take each individual specific situation into account as you make your nursing diagnoses, but depends on what the cause is, but you have a few of them here. We have to talk about the physiologic changes in pregnancy that affect trauma care. So after a traumatic injury, a woman's body will always try to maintain her own homeostasis at the expense of the fetus. Now, the woman's total plasma volume increases during pregnancy. We already talked about that in second semester, where we know how the blood volume increases hugely. It goes from 2,600 milliliters to 4,000. And this serves as a safeguard if bleeding occurs, because they have so much, but they can lose more blood than normally before. They can actually lose more before you would see hypovolemia. But it also means that she needs more fluid replacement to just restore that circulatory volume. So she's got a lot of extra, and so there is a little bit of a cushion, but she can also bleed a lot more blood. There is approximately 1/6 the total blood volume present in the placenta at all times. Therefore, if you have a uterine laceration, it's always serious because you can lose up to 1/6 of your blood volume very, very quickly. Other things that are going on is that the peripheral blood flow is increased in pregnancy. So a pregnant woman can be in severe shock and they don't always have those cool and clammy extremities that we would see with other shock situations. And abdominal pain, if they have a trauma, is difficult to localize because the organs are pushed aside by the growing fetus. So you're not even able to figure out what organ is involved. And during pregnancy, it's normal to have the white blood cell count elevated. Therefore, it's very difficult to use that as a determination of infection if they do have an open wound. And we always want to think about the bladder being so susceptible to rupture because it is the most anterior organ during pregnancy, and it is elevated abnormally. So it's easier it's in a position that's easier to rupture. So nursing care and management, we need to assess quickly when we have a trauma, but we have to be very thorough. Include the psychologic as well as physical status. Assess the fetal status as well as mom's. Locate her support people. We need to know about her current health and her pregnancy history. We need to do a physical exam, and we have to think about those vital areas. Evaluate her lung, heart, brain, and placental function first. You may not have time for all the other areas. The focus is on immediate stabilization, and we have to keep in mind that if the pregnant woman does not survive, we may need to do what's called a post-mortem C-section to save the fetus. We would attempt to do this if the fetus is greater than 24 weeks and fewer than 20 minutes since the mother's death. It's not always effective, but it is an attempt to save that fetus. This is where we're going to end this section of the taping, and we'll talk about intrapartum complications in the next section.